Viral transmission to newborns happens through distinct pathways that require different prevention approaches. During the perinatal period, we see four main routes. Transplacental transmission occurs when viruses cross the placental barrier. HIV and hepatitis B are classic examples that can infect the fetus while still in utero. Birth canal exposure represents a critical window where viruses like HSV and HIV can transmit during delivery through direct contact with infected maternal secretions. Blood and body fluid contact during delivery creates another transmission opportunity, particularly concerning when maternal viral loads are high. Ascending infections occur when pathogens travel upward through the cervix, often associated with prolonged rupture of membranes. Postnatal transmission continues the risk beyond delivery. Breast milk transmission affects viruses like HIV and CMV, requiring careful feeding decisions in infected mothers. Respiratory droplet transmission becomes relevant for viruses like RSV, which can spread through the NICU environment. Contact with infected secretions remains a concern, whether from caregivers or contaminated surfaces. The timing of exposure fundamentally shapes our prevention strategies. Antenatal interventions like antiretroviral therapy for HIV-positive mothers can dramatically reduce transplacental transmission. Delivery planning, including cesarean sections for active HSV lesions, targets birth canal exposure. Postnatal decisions about feeding methods and isolation precautions address the ongoing risks. Each pathway demands specific interventions timed to interrupt transmission at its most vulnerable point. Without any intervention, HIV passes from mother to baby in about 25 to 30% of pregnancies. When we use our full prevention toolkit, we can get that down to less than 1 or 2%. Most transmission happens during 3 different periods. About 25 to 40% occurs in utero when the virus crosses the placenta. The biggest risk comes during delivery. 60 to 75% of transmission happens when the baby passes through the birth canal and gets exposed to maternal blood and secretions. Breastfeeding accounts for another 15 to 20%. Several maternal factors increase the odds of transmission. High viral load means more virus circulating, so there's more chance the baby will encounter it. Low CD4 counts tell us the mother's immune system isn't controlling the virus well. When membranes rupture early and stay broken for hours, the baby sits in amniotic fluid that might contain virus, extending the exposure time. Prevention works by attacking each route of transmission. We start with the mother. Antiretroviral therapy drives her viral load down to undetectable levels, which means there's essentially no virus for the baby to encounter. We keep her on treatment right through delivery because that's when risk peaks. If her viral load is still over 1,000 at delivery time, we do a scheduled C-section to avoid the prolonged exposure that comes with vaginal delivery. For the baby, we start AZT within 4 to 6 hours of birth. Any virus that got through during delivery needs to be suppressed immediately before it can take hold. How long we treat depends on how risky the situation was. In places like the US, where formula is safe, we skip breastfeeding entirely to eliminate that 15 to 20% risk. When we put all these pieces together, we prevent transmission in over 98% of cases. Each step blocks the virus at a different point in the process. How aggressively we treat the baby depends on transmission risk. Low-risk babies, those born to moms with viral loads under 50, get AZT alone for 4 to 6 weeks. When mom's virus is that well controlled, basic coverage is usually enough. Higher-risk babies need more firepower. We use 3 drugs. XCT plus lamivudine plus nevirapine. This might be a baby whose mom had detectable virus, didn't get good prenatal care, or had delivery complications. Treatment duration varies depending on how many risk factors we're dealing with. Sometimes a baby tests positive right away. We don't wait around for confirmatory testing. We start 3-drug antiretroviral therapy immediately. Getting treatment started early can sometimes prevent the virus from establishing permanent infection. We watch carefully for side effects with any regimen. AZT commonly drops blood counts, so we're checking hemoglobin regularly. Nevirapine can hurt the liver, so we monitor liver enzymes. It's always a balance between preventing HIV and managing medication toxicity. Regular HIV antibody tests don't work in babies. The mother's HIV antibodies cross the placenta and stick around for up to 18 months, so the baby tests positive whether they're actually infected or not. We need tests that look for the actual virus, DNA or RNA PCR tests that can tell the difference between the baby's infection status and mom's leftover antibodies. We test first at 2 to 3 weeks old, again at 1 to 2 months, and do a final test at 4 to 6 months. If we get a positive result, we repeat it right away to make sure it's real. We need 2 positive tests before we diagnose HIV infection. This protects us from false positives while still catching real infections early enough to start treatment when it can do the most good. In the US and other developed countries, HIV-positive mothers cannot breastfeed. Period. That 15 to 20% transmission risk through breast milk isn't acceptable when safe formula is available. We have programs that provide free formula, so cost isn't a barrier. This includes pumped breast milk, which carries the same risk as nursing directly. HIV-positive mothers also can't donate to milk banks because it would expose other babies to the virus. The calculation changes in resource-poor settings where clean water and safe formula might not exist. In those situations, exclusive breastfeeding while mom stays on antiretroviral therapy might actually be safer than giving contaminated formula. Mixed feeding, combining breast milk and formula, creates the worst scenario because it damages the baby's gut while still providing HIV exposure. The feeding decision comes down to comparing HIV transmission risk against the dangers of unsafe formula preparation in each specific situation. Most HIV-exposed neonates are asymptomatic at birth, making clinical recognition challenging. When symptoms occur, failure to thrive and feeding difficulties are often the earliest signs. Recurrent bacterial, fungal, or viral infections should raise suspicion. Physical examination may reveal lymphadenopathy, hepatosplenomegaly, or signs of neurodevelopmental delay including microcephaly. Antiretroviral therapy must begin within 6 to 12 hours of birth. Standard regimen is zidovudine for 6 weeks minimum. High-risk cases require combination therapy with zidovudine, lamivudine, and nevirapine. PCP prophylaxis with trimethoprim sulfamethoxazole begins at 4 to 6 weeks. NICU management requires standard precautions only. Formula feeding eliminates ongoing transmission risk in resource-rich settings. Laboratory monitoring includes viral load at 2 to 3 weeks and monthly CD4 counts to assess treatment response. Avoid live vaccines due to risk of disseminated infection in potentially immunocompromised infants. Monitor for zidovudine toxicity, including anemia and neutropenia. Hepatitis B transmission risk depends heavily on the mother's infection status. When mothers are HBsAg positive only, transmission occurs in about 10 to 20% of babies. But when mothers are both HBsAg positive and HBIG positive, transmission jumps dramatically to 90%. HBIG indicates active viral replication. Essentially, the mother is producing massive amounts of virus. High viral load creates similar risk, reaching up to 90% transmission. Most transmission happens during the perinatal period, particularly during delivery when babies get exposed to maternal blood. In utero, transmission is actually uncommon. Less than 5% of cases. The placenta provides pretty good protection during pregnancy, but delivery is where the real danger lies. Here's what makes neonatal hepatitis B so concerning. When babies get infected, 90% develop chronic infection. Compare that to adults, where only 5% become chronically infected. A baby's immature immune system can't clear the virus the way an adult's can, so the infection persists for life. This sets them up for cirrhosis and liver cancer decades later, which is why prevention becomes absolutely critical. Every single baby gets hepatitis B vaccine within 24 hours of birth, regardless of maternal status. This universal vaccination is the foundation of our prevention strategy. All babies need to complete the full 3-dose series for long-term protection. When mothers test positive for HBsAg, we add hepatitis B immune globulin within 12 hours. And earlier is definitely better. HBIG provides immediate passive immunity, while the baby's own immune response develops from the vaccine. We give the vaccine and HBIG at different injection sites to avoid interference. Documentation of timing is crucial because the window for effectiveness is narrow. If maternal status is unknown, we still give the vaccine within 12 hours while urgently testing the mother. We can't afford to wait for results when the transmission window is so critical. If she turns out to be positive, we can add HBIG as long as we're still within that 12-hour window. This approach ensures no baby misses protection due to incomplete maternal testing. Neonatal hepatitis B earns the title silent enemy because 90% of infected babies show absolutely no symptoms at birth. There are no pathognomonic findings that scream hepatitis B infection, no early warning signs that alert you to the problem. The baby looks completely normal while harboring an infection that will silently damage their liver for decades. Diagnosis relies entirely on maternal HBIG status as your primary clue, followed by infant serology testing at 9 to 12 months. You cannot and should not try to diagnose neonatal hepatitis B based on clinical symptoms because they simply don't exist in the newborn period. This is exactly why prevention becomes so critical. These babies develop silent chronic infection in 90% of cases when infected. The virus quietly establishes persistent infection, leading to cirrhosis and hepatocellular carcinoma 20 to 30 years later. By the time symptoms appear, irreversible liver damage has already occurred. The only way to protect these babies is through aggressive prevention at birth, because once infection occurs, the clinical course is typically silent until serious complications develop in adulthood. Hepatitis B virus infection in the newborn is most often clinically silent due to the immature neonatal immune system, which mounts a minimal inflammatory response in the acute phase. This limited immune activation explains the frequent absence of symptoms at birth. When present, low birth weight and prematurity may reflect in utero effects of chronic maternal infection, including placental inflammation and impaired nutrient transfer. Poor feeding and lethargy occur as a consequence of systemic illness and the metabolic disturbances associated with hepatic dysfunction. Mild jaundice is the earliest visible sign, resulting from unconjugated and conjugated bilirubin accumulation due to hepatocellular injury and immature conjugation pathways. In more severe presentations, progressive jaundice accompanies hepatomegaly, reflecting both hepatocellular swelling and inflammation. Coagulopathy indicates significant impairment of hepatic synthetic capacity, particularly in the production of clotting factors. The underlying pathophysiologic hallmark of perinatal transmission is viral persistence. Because the neonatal immune system fails to mount an effective cytotoxic response, over 90% of infected infants develop chronic hepatitis B, placing them at substantial lifetime risk for cirrhosis and hepatocellular carcinoma. Management of hepatitis B exposure in the neonatal period centers on preventing viral establishment rather than treating established disease. For any infant born to a mother who is hepatitis B surface antigen positive, identification and intervention must occur immediately after delivery. Administration of the hepatitis B vaccine within the first 12 hours initiates active immunity, priming the infant's immune system to recognize and respond to the virus. Concurrent administration of hepatitis B, immune globulin, injected at a separate site, provides passive immunity through high-titer neutralizing antibodies, offering immediate protection while the vaccine response develops. In the NICU, antiviral therapy is not indicated for acute infection in otherwise stable neonates, as the focus is on prevention of chronic carriage rather than viral clearance in the acute phase. The initial vaccine dose must be followed by completion of the primary series according to recommended intervals to maintain long-term immunity. Post-vaccination serologic testing at 9 to 12 months confirms both the absence of infection and the adequacy of the immune response, allowing early identification of vaccine non-responders who remain at risk. RSV stands as the most common respiratory pathogen in infants and young children. Nearly every child gets infected by age 2. It's essentially unavoidable. The virus follows predictable seasonal patterns, typically circulating from November through March, though there are regional variations. Southern states often see earlier onset compared to northern regions. What makes RSV particularly challenging is that reinfection happens commonly because immunity after infection is incomplete. Children can get RSV multiple times, though subsequent infections are usually milder than the first. The peak severity occurs at 2 to 3 months of age. This timing matters because babies this young have the smallest airways and least developed immune responses. Their narrow bronchioles get plugged more easily with inflammatory debris, and they can't generate strong cough reflexes to clear secretions effectively. This age group also has higher metabolic demands and less respiratory reserve, making them more vulnerable to respiratory compromise when RSV hits their lower airways. Prematurity represents the strongest risk factor for severe RSV disease. Babies born before 32 weeks face the highest risk because their lung development is incomplete. They have fewer alveoli, less surfactant production, and weaker respiratory muscles. Their airways are proportionally smaller, so even minor inflammation causes significant obstruction. Chronic lung disease and bronchopulmonary dysplasia create ongoing vulnerability. These babies already have compromised lung function and abnormal airway reactivity, so RSV infection can tip them into respiratory failure more easily. Hemodynamically significant congenital heart disease increases risk through two main mechanisms. Lesions with increased pulmonary blood flow create pulmonary edema that worsens with RSV inflammation. Cyanotic heart disease means these babies are already operating with lower oxygen reserves, so any additional respiratory compromise becomes dangerous quickly. Other risk factors include neuromuscular disease, where weak respiratory muscles can't handle increased work of breathing, immunodeficiency that impairs viral clearance, and multiple birth status, which often correlates with prematurity and lower birth weight. RSV typically starts as an upper respiratory infection that looks like a common cold. Babies develop clear rhinorrhea, nasal congestion, low-grade fever, and decreased appetite. Many parents initially think it's just another minor illness. About 20 to 30% of children progress to lower respiratory involvement, and this is where RSV becomes dangerous. You'll see tachypnea as babies work harder to breathe, visible retractions as they use accessory muscles, and audible wheezing or fine crackles on examination. Hypoxemia develops when inflamed airways and mucus plugging impair gas exchange. Apnea represents a particularly concerning manifestation, especially in premature infants. The mechanism isn't completely understood, but RSV can trigger central apnea even in babies who don't appear severely ill otherwise. This is why many RSV-positive preterm babies get admitted for apnea monitoring even when their respiratory symptoms seem mild. Bacterial superinfection can complicate the clinical picture, typically with organisms like Streptococcus pneumonia or Haemophilus influenzae, taking advantage of damaged respiratory epithelium. RSV management centers on comprehensive supportive care since no specific antiviral therapy has proven consistently effective. Maintaining adequate oxygenation becomes critical as these infants develop hypoxemia from bronchiolitis and pneumonia. Supplemental oxygen corrects hypoxemia, while nasal CPAP or high-flow nasal cannula with heated humidified air can improve ventilation and oxygenation when standard oxygen delivery proves insufficient. Airway clearance through gentle suctioning helps manage the thick secretions characteristic of RSV bronchiolitis. However, chest physiotherapy hasn't shown clinical benefit and isn't recommended. Hydration support requires careful attention since infants with bronchiolitis have elevated antidiuretic hormone levels, predisposing them to hyponatremia. When oral intake becomes poor, IV fluids or nasogastric feeds become necessary, but fluid management must be judicious. Regarding antiviral therapy, ribavirin shows minimal clinical benefit despite in vitro activity against RSV. A Cochrane review of 12 trials found insufficient evidence supporting its use, and while it may cause small improvements in oxygenation, it doesn't decrease ICU admissions, length of stay, or ventilation requirements. Given the significant cost and potential toxicity to patients and staff from aerosol administration, ribavirin use remains extremely limited, reserved only for severe cases in high-risk patients after careful risk-benefit analysis. Strict infection control prevents nosocomial spread in NICU settings. Contact precautions with gowns, gloves, masks, and goggles effectively reduce hospital transmission. Staff shouldn't care for infected and uninfected infants simultaneously, and hand hygiene before and after patient care remains essential. During outbreaks, laboratory screening and patient segregation become critical containment strategies. Palivizumab is a humanized monoclonal antibody engineered to recognize and bind to the fusion, or F, protein of the respiratory syncytial virus. This F protein is critical for viral entry, as it mediates fusion of the viral envelope with the host respiratory epithelial cell membrane. By binding to this protein, palivizumab effectively blocks the fusion process, preventing the virus from entering and infecting host cells. This action provides passive immunity, immediate, short-term protection, which is essential for high-risk neonates during the RSV season. It is important to emphasize that palivizumab functions solely as prophylaxis. It does not treat active RSV infection, and once viral replication is established within host cells, its effect is negligible. Palivizumab approval targets the highest risk populations, where hospitalization prevention justifies the enormous cost. Babies born before 29 weeks gestational age get coverage during their first RSV season because their lung immaturity creates such high risk for severe disease. Premature infants under 32 weeks with chronic lung disease requiring ongoing respiratory support qualify because they have both prematurity and existing lung damage. The combination makes RSV potentially life-threatening. Hemodynamically significant congenital heart disease under 24 months qualifies because cardiac lesions worsen RSV outcomes significantly. Anatomic airway abnormalities under 24 months get coverage because structural problems compound RSV-induced airway obstruction. Severe immunodeficiency under 24 months qualifies since these children can't clear the virus effectively. Note what doesn't qualify: cystic fibrosis alone doesn't meet criteria unless other risk factors exist. Down syndrome by itself also doesn't qualify, despite increased respiratory infections in this population. The criteria focus on the conditions with the strongest evidence for severe RSV outcomes. Palivizumab dosing is 15 milligrams per kilogram intramuscularly every month. Treatment starts before RSV season begins and continues through the entire season, typically 5 doses total. The goal is maintaining protective antibody levels throughout the period of highest risk. Breakthrough infections can still occur because palivizumab provides passive immunity that gradually wanes between doses. The medication doesn't interfere with routine vaccinations, so normal immunization schedules continue unchanged. Clinical trials show palivizumab reduces RSV hospitalization by 45 to 55% in high-risk populations. While substantial, this means some protected babies still get sick enough to need hospitalization. The cost is staggering, approximately $2,000 per dose, making a full season cost around $10,000 per infant. This expense requires careful selection of truly high-risk candidates. If a baby develops RSV infection during the season, palivizumab gets discontinued since they're now dealing with active disease rather than prevention. Nirsevimab, marketed as Beyfortus, represents a significant advance in RSV prophylaxis strategy. Unlike palivizumab, which requires monthly dosing, nirsevimab's FC region contains an YTE amino acid substitution, which increases binding affinity to the neonatal FC receptor, extending its serum half-life to approximately 5 months. The target is the RSV fusion, or F, protein, specifically in its prefusion conformation, the state most vulnerable to antibody neutralization. By locking onto this site, the antibody prevents the conformational change required for viral envelope fusion with the respiratory epithelial cell membrane. The FDA approved Beyfortus for all infants born during or entering their first RSV season, regardless of gestational age, and for select high-risk children up to 12 months old during their second season. This broader indication reflects its ability to provide universal seasonal coverage with a single intramuscular dose, which has substantial implications for both inpatient NICU discharge planning and community-level RSV prevention programs. Phase 3 trials, including the MELODY and HARMONY studies, demonstrated that a single dose of nirsevimab reduced the risk of medically attended RSV lower respiratory tract disease by roughly 70 to 75%, and RSV-related hospitalization by close to 78%. Importantly, these trials included both term and preterm infants, supporting its universal application in the first RSV season. The dosing strategy is straightforward, but weight-based. 50 milligallons for infants under 5 kilograms, and 100 milligallons for those at or above this threshold. Administration is intramuscular, typically in the anterolateral thigh. For NICU patients, the timing is critical. Ideally, the dose is administered before discharge if this coincides with RSV season onset, ensuring immediate coverage in the vulnerable early weeks at home. Safety data are favorable, with most adverse events limited to self-limited rashes or injection site reactions. Rare hypersensitivity, including anaphylaxis, has been reported, reinforcing the need for brief post-injection observation. From a health system standpoint, the greatest current limitation is supply. In seasons with restricted availability, allocation should prioritize infants with the highest risk of severe disease, particularly those with significant prematurity, chronic lung disease, or hemodynamically significant congenital heart disease, while still aiming for broader seasonal protection as manufacturing capacity improves. This table outlines the primary differences between Beyfortus and palivizumab without interpreting them. Both are monoclonal antibodies directed at the RSV fusion protein, but nirsevimab is engineered with an Fc modification that extends its half-life, allowing for a single seasonal dose, whereas palivizumab requires monthly injections to maintain protective serum levels. The indication scope differs. Beyfortus is approved for universal use in the first RSV season and for certain high-risk children in their second, while palivizumab is limited to high-risk groups. Efficacy data come from different trial eras and designs. Nirsevimab's major studies, such as Melody and Harmony, reported about a 78% reduction in RSV hospitalization, while palivizumab's IMPACT RSV trial found about a 55% reduction. These figures are not directly comparable because of differences in study populations and RSV epidemiology at the time. Both agents are delivered intramuscularly and have similar safety profiles, with most adverse events being mild and localized. Non-polio enteroviruses include several virus families that commonly affect newborns: Coxsackie A and B viruses, echoviruses, and the newer enterovirus types 68 through 71. Perinatavirus creates similar clinical presentations and gets lumped together because doctors often can't distinguish them clinically. These viruses spread through both fecal-oral and respiratory routes. The fecal-oral route means contaminated hands, surfaces, or water can transmit infection. Respiratory droplets also carry the virus, especially in crowded settings like NICUs, where multiple babies might be affected. Summer and fall represent peak seasons for enterovirus activity, unlike winter respiratory viruses. This timing helps with clinical suspicion when you see clustering of cases during warmer months. Both vertical and horizontal spread occur. Vertical transmission happens when infected mothers pass virus to babies during delivery or shortly after birth. Horizontal spread occurs between babies in the NICU, from caregivers to babies, or from family members to babies. The dual transmission routes mean outbreaks can involve both newly delivered babies and those who've been in the unit for weeks. Aseptic meningitis represents the most common enterovirus syndrome in newborns. Babies present with fever and irritability, often the only signs in very young infants. Lumbar puncture shows cerebrospinal fluid pleocytosis with elevated white cells but negative bacterial cultures. Most cases follow a benign course with supportive care, though the clinical picture can be frightening for families. Myocarditis creates the most dangerous enterovirus syndrome with mortality rates between 50 and 80%. The virus directly attacks heart muscle, causing cardiac dysfunction that can progress rapidly to cardiogenic shock. Arrhythmias develop as the infection disrupts the heart's electrical system. Some babies present with sudden cardiovascular collapse, while others show gradual onset of feeding intolerance and respiratory distress. Hepatitis with coagulopathy occurs when enterovirus targets liver cells, causing acute hepatic dysfunction. The liver damage impairs synthesis of clotting factors, leading to bleeding complications that can be life-threatening. Sepsis-like syndrome mimics bacterial sepsis with fever, lethargy, poor feeding, and hemodynamic instability. This presentation often leads to empiric antibiotic treatment while awaiting viral test results. The neonatal period creates the highest risk for severe enterovirus disease. Newborns lack mature immune responses and may not have protective maternal antibodies, especially if mom wasn't exposed to the specific enterovirus strain recently. Premature babies face additional risk due to their immature immune systems and often limited maternal antibody transfer. Red flags indicate potentially severe disease progression. Myocarditis signs include poor feeding, tachycardia, gallop rhythm, or signs of congestive heart failure like hepatomegaly. Hepatic failure manifests as jaundice, coagulopathy with abnormal bleeding, or hypoglycemia from impaired glucose production. Disseminated intravascular coagulation suggests widespread tissue damage and systemic inflammation. Multi-organ involvement, such as combined cardiac, hepatic, and neurologic symptoms, indicates severe disease that often progresses rapidly. These poor prognostic signs help identify babies who need intensive monitoring and aggressive supportive care. Unlike bacterial infections where antibiotics can alter the course, enterovirus treatment remains supportive, making early recognition of severe cases crucial for optimizing outcomes through intensive care management. RT-PCR remains the diagnostic gold standard for neonatal enterovirus. Obtain comprehensive sampling, CSF, blood, throat, and rectal swabs. Single specimens are inadequate. CSF analysis typically demonstrates pleocytosis with normal to mildly elevated protein, distinguishing it from bacterial meningitis. Management centers on aggressive supportive care. No FDA-approved antivirals exist for routine use. Prioritize fluid management, hemodynamic support, and respiratory interventions based on clinical severity. Plecanaril may be considered for severe CNS cases through compassionate use protocols. IVIG has limited evidence but may benefit immunocompromised infants. Monitor aggressively for myocarditis. This complication can be rapidly fatal and requires immediate cardiology consultation. Neurologic complications, including aseptic meningitis and encephalitis, demand intensive monitoring. Systemic complications include hepatitis and coagulopathy in severe cases. Maintain contact isolation until asymptomatic to prevent nosocomial transmission. SARS-CoV-2 vertical transmission remains rare, occurring in less than 2% of pregnancies from infected mothers. Most neonatal infections happen postnatally through exposure to infected family members or healthcare workers rather than during delivery. Clinical features in newborns often remain mild or completely asymptomatic. When symptoms occur, fever and respiratory signs like tachypnea or mild retractions are most common. Gastrointestinal symptoms appear frequently, including feeding intolerance, vomiting, or loose stools, sometimes the only manifestation of infection. Current recommendations favor keeping mothers and babies together rather than separation, recognizing that the bonding and breastfeeding benefits outweigh the low transmission risk. Breastfeeding is actively encouraged because breast milk provides protective antibodies, and the nutritional benefits remain important even if the mother is infected. Standard precautions plus droplet precautions protect healthcare workers and other patients. This means gowns, gloves, eye protection, and surgical masks when caring for suspected or confirmed cases. Outcomes in neonates are generally excellent, with severe disease being uncommon. Most infected babies recover completely with supportive care, reflecting the milder disease patterns seen across pediatric age groups. Ophthalmia neonatorum means conjunctivitis occurring in the first month of life. The timing of onset gives you critical clues about the likely cause, and this timing pattern is something you need to recognize quickly. Day 1 conjunctivitis is almost always chemical irritation from the prophylactic eye ointment we give at birth. The antibiotic ointment can cause mild inflammation that looks like infection but resolves on its own. Days 2 through 5 suggest gonococcal infection. Gonorrhea moves fast. It can cause severe purulent conjunctivitis that progresses rapidly to corneal perforation if not treated immediately. This timing reflects the organism's aggressive nature and short incubation period. Days 5 through 14 point toward chlamydia. Chlamydia has a longer incubation period than gonorrhea, so symptoms develop later. The conjunctivitis tends to be less purulent than gonococcal disease, but can still cause significant inflammation. HSV and other bacterial causes have variable timing, which makes them harder to predict based on onset alone. This is why every case of neonatal conjunctivitis needs evaluation with gram stain and culture. You can't rely on timing alone for diagnosis, and missing a serious infection like gonorrhea can lead to blindness. Gonococcal conjunctivitis represents the most urgent form requiring immediate systemic intervention. Neisseria gonorrhoeae penetrates intact corneal epithelium, causing perforation within 24 to 48 hours without adequate treatment. High-dose systemic ceftriaxone achieves therapeutic levels in ocular tissues, while concurrent topical therapy provides additional local antimicrobial coverage. Chlamydial conjunctivitis demonstrates treatment failure rates approaching 20% with incomplete erythromycin courses. Azithromycin provides superior bioavailability and compliance advantages. Topical antibiotics fail to achieve the intracellular concentrations required for chlamydial organism eradication. Systemic treatment is essential, as 50% of infants with chlamydial conjunctivitis develop concurrent pneumonia. This afebrile pneumonia presents 2 to 12 weeks post-birth with characteristic staccato cough and tachypnea. Chemical conjunctivitis from prophylactic agents demonstrates predictable resolution patterns, typically peaking at 24 hours and clearing by 48 hours. Symptoms persisting beyond this time frame indicate infectious etiology requiring further evaluation. Bacterial isolates require targeted antibiotic therapy based on sensitivity patterns. Clinical response should be evident within 48 to 72 hours of treatment initiation. Progressive symptoms or corneal involvement indicate treatment failure and potential progression to endophthalmitis. Early ophthalmologic consultation prevents irreversible visual complications.